Welcome back to the deep dive. Today, we're diving into Parkinson's disease pharmacology. It's complex stuff,
It really is. But we're here to, cut through that complexity
right? Taking all that dense source material from the pharmacology text.
and giving you the core information you need, how the drugs work, and critically, how you manage them safely as a nurse.
That's the mission. Shortcutting that learning curve. So
Yeah.
Parkinson's, where do we even start? The root cause.
Exactly. It all boils down to an imbalance in the brain, specifically the basal ganglia. You get this major drop in dopamine.
Dopamine, that's the inhibitory neurotransmitter.
Correct. And because those dopamine-producing neurons in the substantia nigra are dying off.
Its counterpart, acetylcholine, which is excitatory, gets kind of out of control.
Precisely. Too much acetylcholine activity relative to dopamine. That imbalance is what drives the motor symptoms we see.
And that's what all these drugs are trying to fix one way or another.
Absolutely. And those symptoms, you really need to know the TRAP acronym. It's key for assessment.
Okay, let's break down TRAP for everyone listening.
Sure. TRAP, T is for tremor, usually starts in a limb, off of that classic pill rolling motion you see when the hand's at rest. It's the first sign for like 70% of people.
Okay, R.
R is rigidity,
Yeah.
that stiffness. When you try to move the patient's limb passively, you feel this resistance, almost like a ratchet. We call it cogwheel rigidity.
Right.
A is akinesia, which really means lack of movement, but it often shows up as bradykinesia, extreme slowness. Think shuffling gait, reduced arm swing, that masked facial expression.
And finally, P.
Postural instability, problems with balance, unsteadiness. This happens later usually, but it's a major cause of falls.
You know, the source material mentions something striking. Symptoms often don't show up until about 80% of the dopamine is already gone.
It's incredible, isn't it? Shows how much the brain can compensate, but also means the disease is quite advanced by the time we diagnose it.
And that probably explains why treatment can be so tricky later on with things like the wearing off phenomenon.
Exactly. Wearing off is when the drug effects just seem to fade away before the next dose is due. Patients feel their symptoms returning.
And then there's the on-off phenomenon.
That's even more unpredictable. Sudden swings between being relatively symptom-free the on time and then suddenly being stiff, slow, and tremulous the off time, it makes managing daily life incredibly difficult.
Which really highlights why the drug regimens get so complex. Okay, let's get into the drugs. First up, the indirect-acting dopaminergics, MAO-B inhibitors like rasagiline, selegiline.
Right. Think of these as dopamine preservers. MAO-B is an enzyme that naturally breaks down dopamine in the brain.
So these drugs block that enzyme.
Exactly. They selectively inhibit MAO-B, so the dopamine that is still being produced sticks around longer, does its job better. This can often help delay the need for levodopa or allow lower doses.
Makes sense. Now, there's a huge safety warning flagged in the sources about MAO-B inhibitors and meperidine, an opioid.
Yes, absolutely critical. Combining an MAO-B inhibitor with meperidine is contraindicated. Full stop.
Why? What happened?
It can trigger a life-threatening reaction. Think delirium, severe muscle rigidity, sky-high fever, hypertensive crisis, possibly related to serotonin syndrome effects. Just don't do it.
Got it. No meperidine. What about the cheese effect? That's always linked with MAO inhibitors.
Right, but that's mainly with the older, non-selective MAO inhibitors interacting with tyramine-rich foods like aged cheese or red wine, causing hypertensive crisis.
So how does that apply here with the selective MAO-B inhibitors?
Well, the selectivity is key. At the recommended doses for Parkinson's, rasagiline and selegiline primarily hit MAO-B, not MAO-A, which handles tyramine breakdown in the gut.
So at normal doses, the cheese effect risk is much lower.
Much lower, yes. Strict tyramine avoidance usually isn't needed, but, and it's important if patients take higher doses, the drugs can lose that selectivity.
And become non-selective, bringing the tyramine risk right back.
Exactly. Then they would need to avoid those foods. Dose matters.
Okay, and one more quick safety point at the sound-alike alert. Selegiline for PD.
It sounds like Selegiline, which is pilocarpine for dry mouth. A mix-up could be really dangerous. Always double check.
Good catch. All right, still in the indirect acting category, what about amantadine? It's a bit different.
Yeah, it's interesting. It started as an antiviral. For Parkinson's, it seems to work by prompting the release of stored dopamine from the nerve endings and also blocking its reuptake a bit. It has some anticholinergic effects, too.
So, multiple mechanisms. When is it used?
Mostly in the early stages. Its effectiveness tends to wear off after, say, 6 to 12 months, but it's found a niche later on, too, specifically for treating the dyskinesia.
Those involuntary movements from long-term levodopa.
Right. It can help manage those.
Okay, now let's talk COMT inhibitors. Entacapone and tolcapone. These work with levodopa, right?
Precisely. COMT, that's another enzyme that breaks down levodopa, particularly out in the body before it reaches the brain. These drugs block COMT.
So they're protecting the levodopa.
Exactly. They prolong the effect of levodopa, make it last longer.
Yeah.
Their main job is to reduce that wearing off phenomenon we talked about. They're used with levodopa.
Makes sense. Now, tolcapone. There's a big warning with that one.
A huge one. Tolcapone has a black box warning for severe liver failure, hepatotoxicity. It's basically caused fatal liver damage in some patients.
Wow. So rarely used.
Very rarely. Only if other treatments haven't worked. And patients need constant liver function monitoring, checking their serum transaminase levels before and throughout therapy.
So entacapone is generally the go-to COMT inhibitor then?
Generally, yes.
Yeah.
Much safer profile. The main thing patients notice is that it can turn their urine a brownish-orange color.
Harmless, but good to warn them about.
Absolutely.
Yeah.
Just so they don't get alarmed.
Okay, shifting gears now. Let's move to the direct-acting dopamine receptor agonists, the NDDRAs. Pramipexole, ropinirole.
Right. These drugs skip the whole dopamine production preservation thing. They basically pretend to be dopamine. They directly stimulate the dopamine receptors in the brain. They trick the brain into thinking there's enough dopamine there.
And when are these used?
Often used as first-line therapy, especially in younger patients, or sometimes added to levodopa. The idea is maybe delaying the need for levodopa itself, trying to put off those motor complications like dyskinesia.
You mentioned pramipexole and ropinirole. What about bromocriptine? That's an older one, right? Ergot derivative?
Yes, bromocriptine is an ergot derivative. It works, but it has more potential side effects, particularly vasoconstriction, because it hits dopamine receptors outside the brain too.
So not great for someone with heart or vascular issues.
Definitely contraindicated in severe ischemic disease, like peripheral vascular disease. The non-ergot ones, like pramipexole and ropinirole, are generally preferred now, often better tolerated, maybe fewer dyskinesias.
Okay, that brings us to the absolute cornerstone, levodopa, usually given with carbidopa.
The gold standard, really. Levati is a precursor to dopamine. It's small enough to get across the blood-brain barrier, which actual dopamine cannot do.
But giving levodopa by itself isn't ideal.
Not at all. Most of it gets broken down in the body before it reaches the brain. This causes a lot of nausea, vomiting, sometimes cardiac dysrhythmias, and you need huge doses to get enough into the brain.
Enter carbidopa. What's its job?
Carbidopa is a peripheral decarboxylase inhibitor. Fancy term, but basically it stops levodopa from being broken down outside the brain.
So it's like a bodyguard, making sure more levodopa actually gets to where it's needed.
That's a perfect analogy. The card that drops levodopa off in the brain. It means we can use much smaller, safer doses of levodopa and drastically reduce those peripheral side effects.
The combination drug is Sinemet. Any key administration points? Like, can you crush the controlled release form?
Generally, no crushing controlled release meds, but Sinemet CR is the rare exception. The source says it can be split once carefully along the score line, but not crushed or chewed.
Okay, important distinction. Now, what about diet? There's a really critical interaction here.
Huge. Protein. High-protein meals can seriously interfere with the absorption of levodopa from the gut into the bloodstream.
So patients need to avoid protein.
No, not avoid it entirely. They still need protein. It's about timing and portion control.
How should they time it?
The advice is to take the carbidopa-levodopa dose, either 30 minutes before eating protein or 1 hour after. Spacing it out helps maximize absorption. Portion control with meat also helps.
Really practical, vital advice. Okay, one last drug class before we hit the nursing process. Anticholinergics, like benztropine. These target the other side of the imbalance.
Exactly. Remember that relative excess of acetylcholine. These drugs block acetylcholine's effects at its receptors.
What symptoms do they help with most?
They're primarily good for tremor and muscle rigidity, that cogwheel stiffness. They don't really do much for the bradykinesia, the slowness.
Okay. And if they block acetylcholine, cholinergic effects are SLUDGE, salivation, lacrimation, urination, diarrhea, GI motility, emesis. So anticholinergics cause the opposite.
You got it. Dry mouth, dry eyes, blurred vision, urinary retention, constipation.
Yeah.
The classic anticholinergic side effect.
Which means we need caution, especially in older adults.
Definitely. High risk for confusion, hallucinations, urinary retention, constipation, falls from blurred vision. Also, a crucial safety point. They impair sweating.
So risk of overheating.
Yes. Patients must be warned to avoid strenuous exercise in hot weather because they can develop life-threatening hyperthermia.
Wow, okay. That's a lot of drug specifics. Let's pivot to the bedside. Given all these mechanisms, side effects, interactions, what are the absolute must-do nursing actions? Assessment first.
Assessment is foundational. Get baseline vitals, of course. But critically, you need supine and standing blood pressures.
Why both?
Orthostatic hypotension, that drop in blood pressure when standing up, is a really common side effect with many of these drugs, especially dopaminergics and COMT inhibitors. Huge fall risk.
Makes sense. And assessing the actual Parkinson symptoms.
Absolutely. Assess the TRAP symptoms regularly. How severe are they? And importantly, how do they impact the patient's ability to do their activities of daily living, bathing, dressing, eating?
What about labs?
Basic renal function, BUN, creatinine. Hepatic function, alkaline phosphatase. And again, if they're on tolcapone, you absolutely need those baseline and ongoing liver function tests, the serum transaminases.
And mental status.
Crucial, especially in older patients. Watch for any new confusion, disorientation, hallucinations, or changes in behavior. These drugs can definitely affect cognition.
Okay, moving to implementation. How we give the meds, timing seems key again.
Yes. Generally, give oral doses with food or meals to minimize GI upset, like nausea.
But wait, didn't we just say separate levodopa from protein?
Good point. Yes, for carbidopa-levodopa specifically, you need that separation from protein. For other PD meds, taking them with a small amount of non-protein food might help with nausea. Also, try to give doses earlier in the day, if possible, several hours before bedtime, as some can cause insomnia.
Got it. Any special techniques, like for that dissolving selegiline?
Right, Zelapar, the orally disintegrating form. It goes on the tongue, let it melt completely, no liquids with it, and the patient shouldn't eat or drink for 5 minutes before or 5 minutes after taking it.
Very specific. And probably the biggest safety instruction for ongoing therapy.
Never stop these drugs abruptly. Patients must be weaned off gradually under supervision. Stopping suddenly can cause a severe worsening of symptoms, almost like neuroleptic malignant syndrome in some cases.
Okay. And promoting physical safety.
Absolutely essential. Teach patients to change positions, slowly sit on the edge of the bed before standing, pause before walking to manage that orthostatic hypotension. Help them hazard-proof their home. Remove loose rugs, ensure good lighting, maybe grab bars.
What about managing side effects like constipation and dry mouth?
Encourage fluids, aim for up to 3 liters or 3,000 milliliters a day if their heart and kidneys can handle it. And boost fiber intake, fruits, vegetables, whole grains. Helps with constipation. Sugarless gum or hard candy can help with dry mouth.
And keep reinforcing that protein timing with levodopa.
Always. It can make the difference between the drug working well or barely working at all.
Finally, evaluation. How do we know the treatment is working?
You're looking for improvement, an improved sense of well-being, maybe better mood or appetite, clearer thinking. Most importantly, improved ability to perform ADLs. And of course, a reduction in the TRAP symptoms. Less tremor, less rigidity, smoother movement, more stable gait.
How quickly should we see effects?
It varies. COMT inhibitors can show benefits like reduced off time within a few days. But for many others, like levodopa or dopamine agonists, it might take 3 to 4 weeks to the full therapeutic effect build up.
What adverse effects need immediate reporting? Signs of trouble?
Definitely report any signs of potential overdose or toxicity, things like excessive twitching, drooling, involuntary eye movements or spasms. Those suggest too much dopamine stimulation, dyskinesia. Also, report severe dizziness, passing out syncope, or new hallucinations right away. So wrapping it up, managing Parkinson's pharmacologically is really about trying to restore that delicate dopamine acetylcholine balance. It's tough because the drugs often lose effectiveness over time.
Leading to those adjunctive therapies, like adding a COMT inhibitor to make levodopa last longer.
Exactly. And from a nursing perspective, it really hinges on meticulous patient education about the drug schedule, the timing, the side effects to watch for, the safety precautions. Adherence is just paramount.
Yeah, the sources really drive home that adherence piece. Missing a dose by even half an hour, it says, can sometimes trigger an off period that lasts for hours.
Yeah.
That's a huge impact on someone's day.
Huge. It dictates their ability to function.
Okay, so here's a final thought, something the source material brings up that's really relevant for you, the learner, thinking about advocacy. There's apparently compelling evidence suggesting that in advanced PD, switching patients from a brand name drug to a generic or even between different generic formulations.
It might actually lead to adverse effects or loss of efficacy for some individuals. The consistency seems to matter immensely.
Right. So the provocative question for you is, How do you balance that very real pressure for cost saving, switching to generics, with the potential clinical risk this poses for a patient living with a chronic, debilitating condition like Parkinson's? Where does patient advocacy fit in?
Something important to think about as you move into practice.